Today the topic which we're gonna study is approach to a patient with arthritis. Remember that when a patient came with an arthritis, we noticed two things. What is a pattern of joint involvement and is there any extra articular manifestation or not? What is meant by the joint pattern? By the joint pattern we mean three things. Whether inflammation exists or not, how many joints are involved and which joint is involved. By inflammation, we mean that whether arthritis is associated with pain, erythema, or swelling, and is there whether there is a morning stiffness which lasts more than 30 minutes. These things will confirm that the arthritis is associated with inflammation. The second one is how many joints are involved. It can be a monoarticular, oligoarticular, and polyarticular. Remember that monoarticular mean involvement of a one joint, oligoarticular mean 2 to 4 joint, and the polyarticular mean that the involvement should be of more than 4 joint. But remember that this criteria vary according to different classification system. The last thing which we notice in pattern of a joint involvement is which joint is involved. Remember that different disease involve a different specific joint. For example, the DIP joint most commonly involved in psoriatic and osteoarthritis, and the same DIP joint is spared in rheumatoid arthritis. There is another disease called as a gout, which most commonly involve a metatarsophalangeal joint, also called as podagra. It is very important to note the pattern of a joint involvement. This will lead us to a specific diagnosis. Apart from the pattern of a joint involvement, the second important thing which we note in a patient with arthritis is an extra-articular manifestation. So what is meant by an extra-articular manifestation? By the extra-articular manifestation, we mean that does a patient have a fever? Is he have a rash on a body? Is there any nodule formation on a body, or is there any myopathy? By myopathy, we mean that is there any kind of muscle wasting of a body or not. By now, we are done with general approach to a patient with an arthritis, that how we will approach a patient and what we will note in a patient with arthritis. Now we will study a step-by-step approach to a patient and we will rule out a different diagnosis. The first step to do in a patient who presented with arthritis is to evaluate that whether the arthritis is monoarticular or a polyarticular. Firstly, we will study an approach to a patient with monoarticular arthritis, and after that we will study an approach to a patient with polyarthritis. So when a patient presented with monoarticular arthritis, the first step is to perform the arthrocentesis and send the synovial fluid for the analysis. If the synovial fluid show WBC count more than 2000, it is an inflammatory monoarthritis, and if the synovial fluid show the WBC count less than 2000, it is a non-inflammatory monoarthritis. Now we will evaluate the inflammatory monoarthritis further. What should be our next step? The next step is to perform whether a gram stain and culture, or we should perform a synovial fluid crystal analysis. If the synovial fluid show a positive gram stain and culture, the patient is suffering from an infective arthritis. If a patient show negative gram stain and culture, the patient have other disease such as an early onset of a rheumatoid or SLE, or patient is suffering from a seronegative spondyloarthropathies. The second cause of inflammatory monoarthritis can be a crystal-induced arthritis. When we send a synovial fluid for a crystal analysis and it show a positive crystal deposition, we will have a two disease such as gout and pseudo gout. After that, we will evaluate the crystal under a microscope. If the microscope show a needle-shaped crystal, we will have the patient is suffering from a gout. If the microscope show a rhomboid-shaped crystal, the patient is suffering from a pseudo gout. So this mark an end of an evaluation of inflammatory monoarticular arthritis. After inflammatory arthritis, now we will study a non-inflammatory monoarthritis. When a patient have a non-inflammatory monoarthritis, the next step is to evaluate whether a patient have a bloody effusion or a non-bloody effusion. If a patient have a bloody effusion, the diagnosis can be a trauma, coagulopathy, and a tumor. If a patient have a non-bloody effusion, the next step in evaluation will be we will perform a radiograph. The radiograph will further narrow the diagnosis, and the diagnosis in a non-bloody effusion will be osteoarthritis, which is the age-related degeneration of a joint. It can be an avascular necrosis. Avascular necrosis means when there is a decreased blood supply to a bone, it will lead to a joint pain. This last one is that patient may be suffering from a Charcot joint. The Charcot joint is a bone and joint change that occurs secondary to a loss of sensation. Mean that the patient will be suffering from some primary disease such as a diabetes, syphilis, syringomyelia, and this will lead to a loss of sensation of a joint, and the patient will have a bone and joint changes. By now we are done with evaluating a patient with monoarticular arthritis. Now come toward a polyarticular arthritis. The first step in evaluating a patient with polyarticular arthritis is to perform a history and physical examination. In history and physical examination, we notice swelling, erythema, and fever. We also perform a ESR test, and after that we send a synovial fluid for analysis. If the synovial fluid analysis show a non-inflammatory polyarticular arthritis, the definite diagnosis will be an osteoarthritis. The osteoarthritis is age-relative degeneration of a joint. Now, if the synovial fluid analysis show that the patient have a inflammatory polyarthritis, what should be our next clinical approach? The next step is to evaluate that whether the polyarthritis occur acutely or chronically. If it occur acutely, it is most commonly associated with an infection such as a gonococcal, viral, Lyme, Ritter syndrome, and a rheumatic fever. If the polyarthritis is inflammatory in nature but occur chronically, it will have a different diagnosis. The disease which cause a chronic inflammatory polyarthritis include a rheumatoid arthritis, SLE, scleroderma, psoriatic arthritis, and it can be any other autoimmune disease. We will study these different diseases in a different video section, but here I will give you a roughly clue to a different diagnosis. In rheumatoid arthritis, there will be a bilateral symmetrical joint involvement, and there will be a morning stiffness which will last more than 1 hour. In SLE, there will be also a bilateral polyarticular arthritis, but the morning stiffness will last less than 1 hour, and there will be a skin manifestation such as a malar rash, oral ulcer, and photosensitivity. The sclerodermal patient will have a fibrosis of a skin and have a sclerodactyly Raynaud phenomena. Now coming toward the psoriatic arthritis. In psoriatic arthritis, there will be a asymmetrical bilateral involvement of a joint. It will predominantly involve a DIP joint. It will affect nails, causing oncolysis, and the patient will have a scaly patches on a body. It's an end of a lecture of how to evaluate a patient with arthritis. If there is any question, you guys can ask in a comment section. Thank you and stay tuned for a more update.